More than 600,000 people die from AIDS every year. Too many women, men, and children are still losing their lives. And yet, nowadays, HIV is treatable. It no longer has to be the death sentence it was at the start of the pandemic in the early 80s. Over 40 million people worldwide are living with the virus. Half of them are in sub-Saharan Africa. There, infection rates have been falling, thanks in part to crucial support from the United States. But since Donald Trump took office, that support was scaled back. And in many other regions, from Asia to Eastern Europe, new infections are rising again. On To The Point, we ask, could the world be facing a new AIDS pandemic? Why is the disease still not curable? And what new therapies are on the horizon? The fight against AIDS. Is HIV still a global threat? Welcome to this week's To The Point. I'm Javier Arguedas. It's good to have you with us. These are today's guests. Dr. Christian Gaebler from Charité, Universitätsmedizin Berlin. He leads the research group on translational immunology of viral infections at the Berlin Institute of Health. Sergiu Grimalschi from Berlin AIDS Support, an organization dedicated to advocacy and community care for people living with HIV. Stegling, Deputy Executive Director at the Joint United Nations Program on HIV/AIDS, joining us from Geneva, Switzerland. And Lillian Petry from Saarbrücken, Germany, originally from Uganda. She's been living with HIV for 25 years, thanks to medical care here in Germany. To all of you, welcome and thank you for being here. Christian, I'd like to start with you. Most people will only sporadically hear about HIV and AIDS in their day-by-day. How would you describe the status quo of the scientific research on AIDS at this very moment?
Yeah, we've made phenomenal strides when it comes to scientific progress and clinical care of this chronic viral infections, which is nowadays a chronic viral infection. As you mentioned in the beginning, it used to be a death sentence. We didn't have treatments, but now for more than 15, 20 years almost, we have good antiretroviral therapy. And right now we're also making great strides in prevention. So it's a bit the victim of its own success that we're hearing less of it, but it's very much not over. So it's really a question of educating, talking about it, and learning what strides have been made, but what strides need to be made to really end this epidemic.
Would you say that prevention is more at the forefront than an actual cure at this point?
Yeah, we have great therapies nowadays. We have great tools for prevention. Some of them are being used, but some of them could be much more improved because we're still seeing high rates of new infections. And then there's this ultimate goal of the 40 million people living with HIV if there's a potential cure. So we're working also relentlessly on this. But in the end, all of these three things need to work together to really bring an end to the epidemic. So we need to prevent new infections. We need to treat new infections, because when we treat, we prevent transmission of the virus, and the people living with HIV, some of them being born with this virus, over 100,000 kids being born every year, which face a lifelong therapy. If we can have an option for a scalable cure that we can bring into the community of people living with HIV, that would really be the third pillar that could bring an end to this epidemic.
We'll take a look at what is at stake and what is possible today. As we just heard, AIDS doesn't need to be a death sentence anymore. New medicines and therapies are bringing real hope. Here's a quick look at the most promising approaches.
This injection marks a turning point in HIV treatment. The active ingredient, lenacapavir, only needs to be administered once every 6 months to suppress the virus in the body. Until now, that required a regimen of a pill every day. Parallel to that, there are other promising research approaches, optimizing the immune system, broadly effective antibodies to neutralize viruses, and the CRISPR-Cas9 gene editing tool. The goal is to detect viruses hidden in the genetic material of immune cells, cut them out, and destroy them. All these studies aim to not only simplify treatment in the long term, but also make a cure possible. The main problem, the HIV virus constantly mutates, changing its outer coat and thus the potential points of attack. That is why the search for a vaccine has been slow for years. Now the first successes have been achieved with mRNA technology that was also used during the COVID pandemic. So, when will there be a cure for AIDS?
We're going to try and find that out. Lillian, how much did you know about the virus and treatment possibilities when you received your diagnosis?
It was not a secret that there was a treatment in the European countries and that we just didn't have access. And that access to tests was also like a luxury. So when we came to Germany those days, it was a law to test everybody who came to Germany. I was among the people who was tested. And you couldn't access the medication immediately if you don't have an insurance. That's why it was a little bit complicated at the beginning. Later, it worked.
Did you know before, but you were aware of your status before you got to Germany?
Yes, I was aware of so many symptoms, but not a test, not tested. I was tested in an asylum process, and immediately my case was so bad, I could not even go back home. I was carried with an oxygen mask and an ambulance to the quickest, nearest station to save my life.
All the more important to have that access. We'll talk about that very important aspect later on. Christina, we know that the 1st of December is World AIDS Day, where there's a big intention to raise awareness and to also think of everyone who has lost their lives to AIDS. What message does the UN want to bring across this year?
So I'm going to hold up our little report. This is what we launched this week for World AIDS Day. And as you can see, our message is around disruption, the severe disruption that we have experienced in the global AIDS response this year, but also about transforming the AIDS response and learning from what we have learned. And I think one sentence to say is when we look at Lillian's story and the access we have nowadays, we have 40 million people living with HIV. Over 30 million people are on treatment. That's a huge success. But unfortunately, we still have 10 million people not on treatment, which is something we should all think about. And unfortunately, we still have over 1.3 million people getting infected with HIV every year.
Let's talk about what's currently the status quo for people living with and without HIV. Sergiu, let's start with prevention. How far do you think has science gone, and how widely spread is the access to that prevention?
I think prevention is accessible in practically every place of the planet, but we have very much marginalized people which are excluded from every form of information and treatment, especially. So the primary prevention for the general populations are working good. The secondary prevention for people living with HIV, it's not so good. And the focused prevention for people who are marginalized and are from special groups like drug user, like migrant people, during the migration, it's very bad. So we have still people who die because of AIDS today in different countries, and two in Germany, migrant people who are arriving here without access to the treatment because they are illegalized. They don't have they are without documents, without access to the treatment. But two people with documents, like for example Ukrainian refugees, after coming to Germany, have to wait 3, 6, 12 months to have a real access, and in this time they have no treatment. And if we think that they are coming from countries where they was excluded from the treatment, for example, for 2-3 years, we have in few months 4-year war in Ukraine, and in the occupied territories, they don't have nothing. So they are coming here and they go to hospital, and some of them are dying. We had 2 weeks ago a young man, 19 years old, coming from Ukraine after the changing of the law about the recruitment for the war, and he was so sick that he died in 2 weeks here, and it's very, very, very sad.
Yes, those the aspect of access again is crucial in this case. Christian, from what I understand, medically speaking, the prevention treatments and the treatments for people who are living with HIV are rather similar. What specifically do these people need, and what would require, the distribution of this specific medicine?
So it's very true. So preventative therapies have a very similar point of attack, basically trying to inhibit viral replication, so the virus building copies. Once you are infected, you need to take these pills on a regular basis to really prevent the virus from replicating, from affecting immune cells, and in the process, eliminating these immune cells that would lead to immunodeficiency, which ultimately is what we call AIDS, so acquired immunodeficiency syndrome. So with these treatments now, they really interfere with this viral life cycle and prevent it from building new copies and killing these immune cells in the process. Preventative treatments, you also take some of these drugs that would basically prevent the earliest infections, basically the virus entering into these cells and introducing the genetic information into the cells, which can then persist for a very long time and lead to chronic infection, for which you then have to take these daily medications.
There is also treatment for people who have already developed the syndrome, if you will. Does that differ from the medicine you just mentioned?
No, these are the same medications. So you need to take these to prevent immunodeficiency. If there's a late diagnosis, someone presenting very late with already signs of immunodeficiency, you would start these. Of course, you have to treat some co-infections that might present at the same time. But you would start these individuals on these antiretroviral medications that can save their lives.
Lillian, you work closely with people that are aware of HIV and that are maybe not that aware of HIV. How broadly do you think society is informed, at least here in Germany, about what it means to live with HIV and what treatment options are available?
So with the support of the Deutsche Aids Hilfe, it is possible in Germany to get access, plus also the volunteers. We have a big volunteer team in the whole of Germany. For example, we have books which we produce like Your Health, Your Rights, or Your Health, Your Faith, which we go with in the communities. We have access to trainings, but it's also not a reliable structure because I've seen a sickness which has been sustainable. Through years, HIV has been sustainable, but our solutions have not been sustainable. We react and we get off and we give medication and we change our minds. We are affected politically, and the HIV virus has been sustainable in its transmission, in its killing people, it's every time changing the form. So the researchers and the medical doctors and the patients have a good network in Germany. There is also, we must say, a lot of racism in the structures. There's also a lot of homophobic contacts with the systems that we cannot really access and treat HIV when we still have other differences to deal with. The medication is here, the tests are available. I'm going back, I don't know why I keep going back to access, because I feel like if there is a way we can work on the access, even the injections are now out. Some people I help are already taking the injection with very good results. But we need a sustainable program, not projects, but a structured system of fighting this pandemic.
How would that solution look like, Christina, if Germany, which of course has a lot of resources, faces all these barriers? I can imagine that that's one of the reasons why worldwide we see so many infections. 1.3 million people still get HIV every year. How would a structured and systematic solution look like?
Look, I think a lot of the elements were already described by Lillian. We know that we are most successful when we have a community health system that works hand in hand with the public health system. We know that because of the stigma, because of the discrimination, many people don't enter the public health system in countries where there is widespread discrimination and in some cases even criminalization of people living with HIV or most at risk of HIV. So it's a very complex complex system, but at the heart of it are communities. And that's one of our major jobs, to figure out in the years to come, how do we make that system sustainable and get it funded, not only from external funding, but also from countries themselves. And we see some positive developments in this regard, especially this year, where we have experienced such a huge shock to the system with the biggest AIDS donor, the United States of America, interrupting their funding at the beginning of the year. They provided over 70% of all AIDS funding in the world. And now we have to really work on creating sustainable systems with the community at the heart, and with governments being able and willing to fund those community systems themselves. Because as Lillian says, we still observe the highest rate of stigma happens in the health system. Even when communities are not stigmatizing, we find that often healthcare professionals are stigmatizing and discriminating against people living with HIV. So we know what to do. We now even have the tools that we have seen, as we've seen in your little teaser, but we need to make it sustainable and funded so it is accessible for everyone.
Some of the problems, stigmatization and, of course, the social aspect, have been around since the very beginning. In June 1981, the first AIDS cases were reported publicly. That was more than 40 years ago. The worst years, with over 40 million lives lost, are behind us thanks to new medicines. But the fight against the disease is far from over, and it surely doesn't only depend on science. Economics and social justice also play a major role.
For years, the mobile AIDS clinic offered help. Often all there was in Hillbrow, a hotspot in the South African city Johannesburg. The HIV rate among sex workers here nearly 100%, yet nurses managed to reduce the infection rate. But now that help has come to an end. Washington has pulled the plug on USAID funding. North Africa and the Middle East are also struggling with the lack of both education and medication. Infection rates have surged, doubling since 2010. The numbers are climbing in Central and South America and in Eastern Europe as well. In Russia, an estimated 1 million people are infected, but only half of them have access to medication because they would have to register for it. And many, especially people who are gay, don't dare to do so for fear of persecution. HIV remains a risk for millions of people worldwide, and the chances of survival are very unevenly distributed across the globe. Does money decide who gets help?
Sergiu, it of course also has to do with money. We're just hearing about the cutting of funding by the United States. Do you feel on a local level, if you say, this shockwave in the fight, in the community that's fighting the disease?
Where in Germany we get funding from the local governments, and this is a good thing. More than 40 years we are supported by the health ministries of the countries, of the lands. I think this is not the problem. The problem is worldwide. Worldwide, we have big problems with the money which don't come from USAID. And we have the problem that in most of the countries, especially in the countries with conflicts like now in Eastern Europe, but two countries with internal crisis, like, for example, in Latin America, Venezuela, Cuba, it's not exist more medicine. That means the people living with HIV in these countries, countries which are in war, or countries with economical crisis, like I said, Cuba, Venezuela, and Haiti, they don't have access to the treatment, and they get the HIV and they die without taking one tablet. And this question is a big universal question which we have to clear. We cannot say, no, it's the local problem of Venezuela or I don't know, of Haiti. We have to look there. The treatment is very bad in some of African countries too, and it's not existing, for example, in the occupied territories of Ukraine, which is a situation which is during not 4 years, but 11 years. Yeah. So 11 years from 2040 in the Donetsk and Donbass area, it's not existing a real treatment. And this is a big part, and if we think a big part of Ukraine. If we think about that in Russia too, the number of people living with HIV, it's about 1.5 million, the unofficial number, and access have only 300,000 people. So you see that the situation, the government, the local government make a selection. So people which are not accepted, like gay people, like drug users, they are practically condemned to die because they are selected in different mode to in different kinds to don't have access to the treatment. And this all it's a tragedy, and we have from one side a very big success with the science and with the medicine, and from our other sides we have problems with the governments and with the original kind of shorting the money for the people.
We see how political aspects and of course wars are playing into this. Christina, briefly, if you can, if the US is cutting funding, which is so crucial, is someone else stepping in more? And if so, who or which countries or organizations?
I know you're saying it's short, but it's complex. So the US paused funding. They have come back. They have just made a huge commitment, and so has the government of Germany, to the Global Fund to fight HIV, TB, and malaria. So that's a good sign. Less money than they used to give to the Global Fund, but still a substantial amount, over $4.6 billion. They're also coming back with their own national HIV strategy, an America First global health strategy. They're in the process of negotiating agreements, country or government to government. We need to see what the outcome of those agreements are to see what resources are available. I think our biggest problem is, will we have enough funding for HIV prevention at a time that we have such wonderful new tools on the market, like lenacapavir, that comes as close as we can get to a vaccine? So that would be a huge breakthrough. And the second thing is, do we have enough money available for community support and supporting the structural drivers of HIV infections? So we are at a crossroads, and our new governments or new countries coming in, very few, but let's also note that China is coming to the table and is funding increasingly HIV programs and health programs in Africa. And countries themselves, as I said previously, are coming in. Some countries, Uganda, Tanzania, South Africa, Nigeria, have increased their health budgets because of what they have expected. President Mahama from Ghana has just announced an African reset, saying we want to be less dependent on external funding for the health of our own citizens. And those are important new issues that are coming up and that we need to follow. So am I hopeful? A little bit. Am I worried? Very much so. But I think there is something on the horizon that we could still reach this target, that we end this pandemic by 2030. And it takes political will. And as the colleague just said, it takes global solidarity. No country will do this by themselves. We need to do this together. This is why we were successful in the first place, and that's what we need to continue.
I wonder, Christian, if you also share...
Can I shortly...
Yes, please.
I just wanted to shortly add on you. We have been teaching about these 17 goals of development in our communities, in schools, in HIV centers. And the goal number 3 is health. That by 2030, we don't have people dying of malaria, dying of HIV, and childbirth. And it is not real, because even when the countries have access to medication or the structures, the people cannot have that minimum $1 transport to go to get the medication. Here I can get in Germany my 3 months package of medication, but my other women whom I'm supporting get tablets counted out of the bottles. They don't have a sealed bottle. They have to keep going to the center maybe per week or per 2 weeks to get. Sometimes the structures, the other problems in the societies are also affecting that the people will not go to take the medication. And I was thinking, for the countries which have like the German country, which is able to give medication for people who are on asylum, that they could give them a right of stay. I can talk for myself. When I was in the hospital, I was not really worried about how I would survive the sickness. I was more worried about a deportation. My mind, my health was pushed by the feelings of deportation, the fears of deportation, and not the fear of HIV. We don't have a right or a law to protect HIV positive people living in Germany. They can be deported with information that their countries have access to medication. And if you come from the capital cities, Nairobi, Kampala, Luanda, then you're good to go. But if you come from my village, you need the 10, 20 euro to be going to access the therapy. And that is not possible.
Another sign of that integral solution that is required, as with so many other problems in this world, unfortunately. Christian, very briefly, I would like to start a closing round with the beginning question of this show, and I would like to start with you. Do you consider that AIDS still is a global risk?
Yes, absolutely. This pandemic is not over, and we need to raise awareness and talk about it.
Sergiu?
I mean, too, HIV, it's a big risk, and we still have people dying on HIV, even in Europe.
Right. Thank you very much to the both of you, and of course also to Lillian and Christina for joining us from afar, and to all of you for watching. That's all for this week's To The Point. We'll see you next time, or on YouTube at any time. Just search for DW News. Take care and goodbye.